My name is Ammar Kheir. A gastroenterologist from the Cleveland Clinic, Abu Dhabi. It gives me great pleasure to introduce my key speakers here. We have Dr. Michael Wallace from Mayo Clinic, Jacksonville, and I have Dr. Moamen from Cincinnati Hospital. So this is part of the podcast we have at the second IGCC meeting. The topic for today will be mainly on pancreatic lesions. So we'll start with Michael on pancreatic cancer. As we know, it's a very notorious disease. We have really poor outcome for those patients. What is the most recent updates on how can we improve our screening? How can we pick up these patients that we may be able to save their lives?
Yeah, thank you, Ammar. I'm actually very glad to report that, we often are quite pessimistic about pancreatic cancer. People know that it has a very high mortality. Often when people hear the word pancreatic cancer, they think there's no treatments. But actually, there's been tremendous progress, especially in the last 5 years, in early detection. And the benefits that we've seen in other cancers, colon cancer, breast cancer, cervical cancer, esophageal cancer, where much of that benefit was driven by early detection. We're now starting to actually see that in pancreatic cancer. We're seeing a shift from detecting most of these at advanced stage, and people who are enrolled in screening and surveillance programs, we're finding it early and much more curable. The big difference with the other cancers I mentioned is that it's still relatively uncommon, and so we don't screen the entire population, because it's not frequent enough to do, for example, a screening MRI on everyone. But what is well established now is that screening individuals who are at increased risk is effective and does lead to higher cure rates. Who is at increased risk? Number one, if you have a strong family history of pancreatic cancer, and that's defined as 2 or more first-degree relatives. They don't have to be first degree to you, but at least one of them has to be first degree to you, your father, mother, brother, or sister. And the second one should be a first degree to that person. So 2 affected members, first degrees, or 3, any members of your family that have pancreatic cancer. So those individuals should consider screening. The other group that we have identified that benefits from surveillance, and we're going to hear much more about that in a moment, are people with cystic lesions of the pancreas. These are like polyps of the colon. They're detected commonly. They're precursors to cancer. And we're going to hear more in a moment about how we screen or follow those. But in the familial group, the current methods that we use to screen those individuals, first, we do genetic testing to see if they have an inheritable pathological variant, such as there's mutations BRCA1 and 2, what are often known as the breast cancer genes, but they also affect the pancreas. Other less well-known ones like CDKN2A, which causes multiple melanomas, as well as pancreatic cancer, and several others like Lynch syndrome, which causes multiple polyps, but also causes pancreatic cancer. In those individuals, either just based on family history or also based on known genetic pathological changes, we enroll them in a screening program. What screening means is every year we image their pancreas. It can either be by MRI or endoscopic ultrasound, or alternating between MRI and endoscopic ultrasound. 2 large studies, one done in the United States called the CAPS Consortium. CAPS is the Cancer of the Pancreas Screening Consortium. And another one in the Netherlands, led by the Dutch group, where there's a large number of individuals with a genetic change that puts them at risk. In both of these large cohort studies, they've shown that people who have screen-detected cancers have a much higher survival, even when you adjust for things like lead time and length time bias. They have substantially higher overall survival, especially when you detect it at stage 1 or the high-grade dysplasia, or what's called PAN and pancreatic intraepithelial neoplasia. So these individuals are really the ones we're targeting. I think if you or one of your patients has this family history or get genetic testing and have a genetic change, even if you're, the member of the family had a breast cancer and they had a BRCA1 or BRCA2 mutation, these are the individuals that should also get screened for pancreatic cancer with the methods I talked about.
Yeah, excellent. Thank you. Now, for the general gastroenterologist, we frequently see, for example, patients who may have an episode of pancreatitis. They're smokers. They have, let's say, one family history, second-degree relative who's had a pancreatic cancer. What do we do with those ones?
Yeah, so that's another at-risk group. So particularly, idiopathic pancreatitis, especially over the age of 50. We know that group, there is a significantly increased likelihood that the underlying cause of that pancreatic cancer, of that pancreatitis, could be an occult pancreatic cancer. So in that individual, let's say over the age of 50, has pancreatitis, you can't explain it by alcohol or some other reason.
Yeah.
We generally wait until the acute episode resolves, and then we do an imaging test, either MRI or endoscopic ultrasound, often endoscopic ultrasound, because we're also looking for occult stones in the bile duct, occult chronic pancreatitis. So it's a good way to follow that patient, is to wait a few months until the pancreatitis settles and then do an endoscopic ultrasound.
And where we are at the moment with liquid biopsy or circulating tumor DNA, is that promising? Where we at the moment?
It is promising. So you probably are aware that the first available liquid biopsy or circulating cell-free DNA test was approved for colon cancer screening just recently. However, the companies that make these tests, it's not just specifically looking for one cancer. They're looking for multiple cancers. Although the first approval was for colon cancer, these tests also are so-called MCED, multi-cancer early detection test. And they detect many of the common cancers, including pancreatic cancer, ovarian cancer, breast cancer, lung cancer, prostate cancer. So they're detecting those cells that have DNA damage or mutations that are circulating in the bloodstream. I think we're going to see, after this first approval that we just saw for colon cancer, we're going to likely quickly see a panel of tests that are approved. Now, I will say that these tests are actually available right now. People can purchase these tests and pay out of pocket. We're seeing that increasingly now that people are choosing to do that. In fact, in our hospital, we've set up a whole separate clinic called the MCED clinic, the multi-cancer early detection, because people are walking in the door and saying, I bought this test, it's positive, but I don't know where the cancer came from. So what should I do? The good news is the test often gives you some clues where it's coming from based on which mutation is detected. And it gives you some clues, should you be looking in the lungs, in the pancreas, in a woman, in the ovaries, to do, for example, a pelvic ultrasound. Quite often we end up doing a whole body MRI scan.
Yeah, excellent. Thank you. Dr. Moamen, another dilemma we have is pancreatic cystic lesions. We frequently encounter them incidentally. And can you help us to understand what is the current update on how to manage these lesions, which method we should use, which one we need to sample, and how do we survey them?
Yeah, that's a great question. And we're seeing this more and more often, at least in the US. Patients now, like who go to the ER, I would say almost every patient will get like an abdominal CT scan for some reason. So with the quality of the scans we have too, now we have those like higher quality CT scans, we're detecting more than ever pancreatic cystic lesions. And that's another, it creates a dilemma because patients come in, they say went to the ER with abdominal pain. That's definitely not related to any pancreas cyst, but they got that CT scan and now it shows a pancreas cyst. What do we do from there? And what's going to be the next step? And it makes sense because also information is available online. Patients Google that and they find that in some cysts, which are actually rare, not the common ones, these can be pre-malignant and it's justifiable and it makes sense. Our goal now is to detect cancers early. Can it be preemptive in treating those cysts if they have malignant potential? So the majority of the cysts, and that's what we typically assure the patient, we have a pancreas cyst clinic at our hospital that basically manages those patients. You get the referral for those incidentally detected cysts. There are some factors that put patients at higher risk, so we become more meticulous with certain cysts, specifically those who have the family history, they have the high risk genes with predisposition to pancreatic cancers, those are automatically transitioned into the screening program for pancreatic cancer with taking those cysts in mind. And Dr. Wallace already explained in detail what can be done for those. So I'll go to those ones who do not have the family history, they do not have the genetic mutations for pancreatic cancers, but they have an incidental cyst. So when we look specifically at that cyst, there are certain criteria that would say this is a higher risk cyst versus none. The types of the cyst, the four major types of those are the IPMN, which divides into two subtypes, a side branch or a main duct IPMN. And then we have the MCN, and we have the pseudopapillary neoplasms, which are very rare, typically a spot diagnosis on imaging, and those can be managed, like typically you have a clear path for those. But the ones that can get mixed up are the side branch IPMN, main duct or combined, and then the MCNs. And we have criteria for which patients need an endoscopic ultrasound, which is basically our tool to get some tissue diagnosis and risk stratify those patients. So patients on imaging who have high risk features like a size of a cyst that's more than 3 centimeters, a presence of a mass within the cyst, narrowing in the pancreatic duct, or an obvious lesion in the pancreas, like a solid lesion in the pancreas. Those patients need to get an endoscopic ultrasound. And when we do the endoscopic ultrasound, we typically evaluate the lesion itself and evaluate the pancreas as well. And when we evaluate the lesion, our goal, if we prove any of these high-risk features, is to get a sample from that cyst. And those samples are sent for cytological analysis. They are sent for tumor marker, which is a CEA. They're sent for other chemical tests like glucose, amylase, and they're also sent for genetic testing. Some of the commercial names is a pancreagen test or the pancreas-seq test, which look for certain genetic mutations like the KRAS, GNAS mutations as well, which can be predictable of transition into cancer. And then once these results are collected, we can determine what type of cyst that is. And typically this is something you can identify on the endoscopic ultrasound. MCN have a specific criteria. They're typically more common in women. You have certain criteria to identify. And then with IPMNs, the concern is basically main duct IPMN and MCN. Those are the ones with higher risk of transitioning into cancer. Side branch IPMN, like per se, are not high risk transition into cancer, unless again you're seeing some cancerous changes already into those cysts. So the ones with the main duct and the MCN are the ones who really become a multidisciplinary patient. These are typically discussed into tumor boards to determine what's the best approach, because those are high risk for transition into cancer. In general, if you have a proven MCN or you have a main duct IPMN specifically, those patients are evaluated for early surgical resection because that improves their outcomes, typically again for main duct IPMN. And then the other patients who do not have those like cancerous changes or like dysplastic changes on cytology, those are typically placed onto a surveillance program. And that surveillance depends on the type of the lesion. Typically, it's imaging within 6 months or a year, and that can be expanded if there is no change into the features of that cystic lesion, which means the lesion is not growing. We're not seeing any internal changes within the lesion. But the whole goal is to detect these changes early on. We know for sure that when you operate onto those patients before there is an overt cancer, outcomes of the surgery, which is whether a Whipple or a distal pancreatectomy, are much better.
Excellent. And let's say they underwent surgical resection and that incidental lesion has been addressed. How frequent should we survey them? Can they have a risk for future metachronous lesions, further lesions?
That's a great point. Yeah. Yes, so they can. So typically there is surveillance imaging after the surgery. The interval varies, again, depending on the initial diagnosis of that. But typically those patients get either alternating endoscopic ultrasound and cross-sectional imaging, or they just rely on cross-sectional imaging. In our institution, they prefer to alternate with endoscopic ultrasound, knowing that there will be restrictions for endoscopic ultrasound depending on the type of the surgery the patient get. Like, for example, if they get a Whipple, there is some limitations with the change in the anatomy. Distal pancreatectomy doesn't change much. You can still look at the pancreatic head because you have a preserved upper GI anatomy, if we would say. But those patients patients continue to be on surveillance after that.
Excellent. Well, finally, if I can ask you both, if you have any final remarks commenting on what the future holds, I guess especially with the integration of artificial intelligence in a lot of parts in medicine, where do you see the future for both lesions?
I think for screening high-risk individuals, and that includes those with pancreatic cystic neoplasms, I think the blood-based testing is likely coming online fairly soon. In addition to that are tests looking at DNA changes directly in the pancreatic juice. So this is also likely going to become commercially available in the quite near future. I would say within the next 12 months. There'll be a commercially available test that looks at DNA changes in the pancreatic juice. So for example, when you're doing that endoscopic ultrasound, we can give secretin, collect the pancreatic juice, and look for altered DNA. That test was actually developed by the same team that developed the Cologuard test. So it's not looking at mutations, it's looking at altered methylation of DNA in the pancreatic juice. And it's now actually been very well validated and is going to become commercially available shortly. So we'll likely add that. And then lastly, using AI algorithms to enhance on the cystic neoplasm side, it's usually followed by MRI. So there are AI algorithms that are becoming very accurate at saying which are low risk and high risk. And this is especially important because most of the lesions we see are actually very low risk. And yet we're subjecting people to quite intensive surveillance for low risk lesions. And even worse, subjecting them to surgery for low risk lesions. On the solid neoplasm side, we're seeing increasing evidence that AI algorithms can predict the future development of pancreatic cancer on a CT scan. There's some very nice work done by a radiologist by the name of Ajit Goenka at the Mayo Clinic in Rochester that takes people that had a CT scan that was read as normal, but 3 to 5 years later developed pancreatic cancer. And so going back in time and running these algorithms on the CT done 3 to 5 years ago is quite accurate at predicting the future development. So all of those CTs done in the emergency room that are read as normal pancreas, I think running some of these AI algorithms and saying this pancreas is not entirely normal. There's something here that we don't see with our eyes, but AI algorithms can pick it up and say this person may benefit from a screening program like what we've talked about. That's coming a little further down. We're not ready to implement those in practice yet, but it's one of the tools that I think is in the pipeline for screening these individuals.
It's amazing.
Amazing.
Moamen, anything you want to add?
Nothing from me to add. I think Mike covered it nicely, and it's really exciting to see these advances in AI and what it can bring forward. I think the whole idea is to also do less surgery if it's not necessary and expose patients to less radiation if it's not necessary, but in the same time not to miss cancers and treat them early. And that's where the sweet spot is.
Fantastic.
Yeah.
Well, thank you both for your time and sharing your expertise. And with this, we'll conclude the podcast, and thank you for listening.